Good afternoon, everyone. Welcome. This is Nancy Metzler from the University of Rochester, and welcome to our webinar, New York versus COVID-19, We Are Winning. We want to thank UNOS for providing us with a platform to present the New York experience with COVID. Many of you provided us with questions when you registered, and we're going to try to answer many of those in our program today. If you have additional questions, you can send them through the chat function on the webinar or send them to Linda Oler, and we will respond to them. If we can't get to them on the webinar, we will respond on the Transplant Administrator and the Transplant Quality listservs. I would also like to personally thank Linda Oler for pulling this webinar together. She did an amazing job, and we really appreciate her and her ability to herd us all into a comprehensive presentation. Next slide. Our goals and objectives for today are to identify the benefits of statewide transplant communication during a crisis such as COVID-19, describe the development of the home care strategies, including telehealth during COVID-19 for our transplant candidates, recipients, and living donors, discuss strategies for maintaining COVID-free units during a surge, examine the complex staffing issues that arose with inpatient and ambulatory care areas, and identify implemented strategies that we hope will continue post-pandemic. Next slide. This amazing group of folks came together to learn from each other, to support each other, and to make it through this together. So we had representatives from all of these organizations join together on our 3 times a week phone calls. The group included transplant administrators, transplant quality staff, physicians, surgeons, OPO clinical and administrative leadership, and of course our outstanding leaders from our statewide organ consortium groups. Next slide. We've learned a lot from each other, a lot about each other, such as who colors their hair, who's turning gray, who's got kids, who's got pets, all sorts of things that we zoomed into our homes and offices on good days and on bad. Next slide. We usually look very happy. Some of these we don't look happy, but anyway, it's a great group of people, and it's been my honor and privilege to work with and learn from all of these folks. So our first speaker today is Samantha Dallaire, and she is from the New York Center for Liver Transplantation, and she is going to speak on behalf of our our statewide organ group. Samantha?
Hey, Nancy, you kind of took my line. I was going to talk about how privileged I worked with all these folks for 16 years. It's kind of funny that we can get a great group picture on video chat when we haven't seemed to be able to accomplish that when the rare occasions we've been together in person. So anyway, my name is Samantha Dallaire, and I am the Executive Director of the New York Center for Liver Transplantation and also the New York Cardiothoracic Transplant Consortium. And I'm also presenting on behalf of our sister organization, NY Kidney, whose Executive Director is Carrie Lindauer. You can go to the next slide. So thankfully, the first New York Transplant Consortium has been in place for over 30 years now, and it's that existing infrastructure and communication that allowed, statewide sharing of our COVID experience early on as the first major wave of patients began to inundate our downstate hospitals. We have 3 statewide organ transplant nonprofits. Each has their own board of directors that drive the activities of the organization. The first consortium was the New York Center for Liver Transplantation, and membership was actually required by the Department of Health to be able to open a liver transplant program. Because if you remember back in 1988, UNOS was just a few years old, and the State Department of Health in New York wanted the central entity to provide a forum for communication and share expertise amongst its members. And most importantly, they were also mandated to share livers that became available for transplantation in the state. Fast forward several years, and the Cardiothoracic Transplant Consortium began in 2011, and that was by recommendation actually of our New York State Transplant Council, which does provide, it's an advisory body that provides information to the Health Commissioner and the New York State Governor, and it's actually made up of appointments by the Governor, the State Assembly, and the Senate. And then finally, the most recent of the three consortia started in 2017 among the kidney transplant programs. And that was more of a community-driven effort, whereas the other two consortia were more state-driven. And it's kind of a testament to the increasingly collaborative nature of the transplant programs in New York State. Their patient advocacy groups are part of the NY Kidney group, and so are the OPOs. It's just allowed for some really great comprehensive statewide projects. And so all of this collaborative work resulted in the state having sort of this ready-made mechanism to work together while we're tackling the challenges that have been really just overwhelming in this global pandemic. And it's really what the consortia were made for. It's made all of the difference. Go to the next slide. So what is our role then in the consortia? We've kind of served as a command central, as we're calling it. It's been a collaborative effort. NY Kidney has provided our Zoom capabilities. We have the call 3 times a week, as Nancy mentioned, on Monday, Wednesday, and Friday mornings. And actually, those still continue. We had one this morning. The Liver Consortium maintains the invite list. We have nearly 50 people that join that video chat each time it occurs on the 3 different days. And that actually represents 30 New York State organ transplant programs across 14 hospital systems. And of course, all 4 of our New York State OPOs are represented as well. Each gives a report and during every call. And frankly, the information disseminated during the calls is unprecedented. You'll hear during this webinar, much as we did day to day on these calls, and it was sort of a fluid agenda. We just didn't necessarily know what was going to be covered at each one, but we heard about the status at the OPOs and hospitals changing daily. We had the OPOs communicating problems or challenges they were having with donor testing, and then when they got some capabilities online, we knew that right away. Transplant programs identified emerging issues with COVID-positive recipients and COVID-positive providers. We learned how programs were maintaining coverage, some creative rotation schedules, and I'm not going to steal everyone's thunder, but suffice it to say it was information overload on many of those calls. It was sort of an accelerated crash course in different ideas as to how we could maintain safety and communication. There were discussions related to telehealth ideas and how to maintain COVID-free areas, and sort of a proactive approach to knowing, what meds might become a shortage. We saw hospitals go from less impacted areas of the state and travel downstate to different hotspots and then take their lessons back home with them. And then, of course, one of the most important things that the consortia did was become an important vessel for data collection. And honestly, I can't say enough about the transplant program data coordinators who would get on calls with us and let us know what they could collect quickly and provide, and what would take a little more time. So we were able to capture a limited data set related to the scale and the scope of the pandemic on our transplant patients and providers. And we were able to update the New York State transplant community on a weekly basis as they were making, decisions on which patients to transplant, if any, at this time. For example, in the first 2 weeks of April, we've done only 1/10 of our normal volume. So that's 23 organ transplants statewide. That's all organs: liver, heart, lung, kidney. That compares, the 23 that we've done statewide this month compares to over 220 some odd transplants that we typically have on average in a month. We've seen our COVID-positive transplant recipients triple in the first week of data collection from 73 to 210, and then nearly triple again 2 weeks later to 596. And that doesn't include the 214 patients that are presumed positive and are being monitored at home. And that's a sort of an artificially low number because some of our transplant programs haven't been able to capture necessarily everyone that's presumed positive at home. We've seen over 200 hospitalizations just this week of COVID-positive recipients, and unfortunately, we've also seen some recipient deaths. We've seen 64 of our recipients die. We've also, though, seen 100 discharged. So it's we're still really in the thick of it. We've also seen transplant staff redeployments to COVID units. Just this week, we saw 62 that have been redeployed. We've had providers become ill, although thankfully those numbers have dropped 50% this week compared to last week. We are preparing this data to be able to share with the broader national community probably in the next week. But some of it is disheartening, but then there is really some bright light, I think, shining at the end. And I think I'll stop there because I only have a few minutes, and I'll turn it over to Janine at Upstate Medical Center, and they can discuss their experience over the past few weeks as being someone who's more on the learning end of this experience, this collaborative experience. Janine?
Thank you, Samantha. Good afternoon, everyone. Again, I'm Janine Morris. I am the interim administrator for Upstate Medical University Hospital's transplant program, and I'm happy to share the administrative perspective of the importance of statewide communication. So there was a rapid flow of information around the pandemic as it began, primarily in New York City. We were getting information from multiple sources, multiple levels of government, the scientific and medical community, as well as within our hospital. We found it very helpful to come together with the transplant community on a daily basis in the beginning, to really kind of share what we've learned and apply it to the care of our patients. It was by talking with centers from across the state, especially our colleagues in New York City, we were able to understand these new care nuances that were born in this COVID prevalent environment. We learned about the worst case scenarios, which allowed us to plan for issues such as PPE shortage, allowed us to plan for surge capacity, allowed us to think about what would we do if our staff was redeployed or if our resources needed to be used by the hospital. We also were able to identify key components that were needed in order to continue transplant activity. Through our conversations, it caused us to reimagine safe pathways for organ transplantation in our organization. So it caused us to think, what is the capability? What are the capabilities of our OR, of our PACU, our inpatient units, our OPO, so that we could plan to continue to serve our mission. The information that we shared and we learned in the conversations also provided me with timely information to share with hospital officers so that the officers were aware of trends in the state and could get an idea about what was needed in terms of support for our program and to continue our mission. By talking with colleagues across the state, we also became aware of tools and resources that we weren't familiar with. Telemedicine, for example, was not a part of our pre-COVID practice, but through our conversations, we learned what our colleagues were using in terms of platforms, how they were deploying it amongst different populations, and I really found that to be very valuable. We learned about home phlebotomy options, different vendors who are offering that service. Was not so much a big need for our community, but it's good to know in case it does become a need. We also learned of sources of COVID testing, and which was especially helpful in the early phases where testing was not abundant, especially not in the central New York area. We were able to learn of who was able to test and what type of turnaround they were offering, and that helped us to plan for successful and the care of our patients. Also, through our collaborations, we were able to share consent forms, learn of consent forms that were COVID specific, that we could quickly turn around and use for our patient population. So in summary, these calls really provided us with actionable information that we needed to protect and care for our patients, staff, and community. And really so grateful to have been a part of this group and a part of this webinar as well. I'm going to turn it over now to Tanya Lyons.
Hi, everyone. Thank you, Janine. My name is Tanya Lyons, and I'm the Quality Assurance Supervisor here at SUNY Upstate Medical University in Syracuse. I'm going to piggyback on what Janine discussed a little bit regarding the importance and value of the statewide communication, especially coming from us as a non-metropolitan center. When news of the rapidly developing scenario in New York City began to emerge, here in upstate, we felt that it was only a matter of time before the gravity of the situation would migrate our way. And it felt daunting to even start thinking about where to begin to maintain the safety of our patients and staff. But we knew we needed to be proactive. The consortia became the hub for data collection, which helped guide us to identify metrics to begin tracking. Each week, a new metric was added that we wouldn't have thought about yet, as not only had we not experienced it, but we couldn't even fathom that some of these things would come our way. For example, tracking the number of staff that were unable to work due to illness or redeployment. Neither of those things had occurred here yet, and so it was helpful for us to anticipate the possibility and develop a platform to track this and develop an action plan. As we all know, transplant is one of the most regulated fields in healthcare. Navigating the policies and regulations of multiple reporting bodies can be difficult without the presence of a pandemic and rapidly changing needs. And by rapid, I mean by the hour, which you'll hear about directly from some of the centers in the epicenter shortly. To have 40 sets of eyes on quickly changing regulations and recommendations from bodies such as CMS and UNOS and the Department of Health and even ASTS, it was incredibly helpful to ensure that we weren't missing anything, including the necessary communication regarding the status of our program, both to patients and to those regulatory bodies. Because we were able to have insight into what was possibly coming our way and were able to learn from programs in the thick of it, we were able to stay ahead of developing policies and protocols within our institution to address the rapidly changing transplant environment. As Janine discussed, we were able to get a consent drafted for our patients regarding the risks of COVID-19, some of which were unknown at the time, to sign during the time of transplant, and we were able to get that pushed through the proper channels in an expedited fashion prior to performing any transplants during this time. We were also able to discuss a protocol and acceptance criteria for organs during this unprecedented time, and we were able to develop a method of continuing to evaluate our pre-transplant patients via telemedicine, thanks to what our colleagues had already started doing in the city. The knowledge of what might be coming our way and the sense of community that strengthened among the transplant centers of New York, the OPOs, and the consortia was invaluable, and we can't thank our transplant family across the state enough for all they've been doing and all that they've been sharing with us. And with that, I'm going to turn it over to Helen Irving from Live On New York.
Good afternoon. I'm Helen Irving. I'm the president and CEO of Live On New York. We are the organ procurement organization that services New York City, Long Island, and about half of the Hudson Valley. And I'm really thankful to have the opportunity to be able to share our experience with all of you. Next slide, please. Very early on, it became pretty clear once we had an executive order from Governor Cuomo for all offices to close in the city that we needed to become a virtual OPO. We had had the benefit of about 5-6 days to plan for this, to take the staff from current state to future state very quickly. And the governor had started to decrease the number of people in the offices gradually over time. And then finally, from March 15th, came the order that 100% of offices should close. We could have taken the position that we are essential, but quite honestly, my administrative staff, QA, community could quite clearly work from home and didn't need to be present in the hospitals. And as you know, clinical staff and hospital development and family services already really work remotely and work from home anyway. So we ended up closing our office. We also had no OPO personnel allowed to be in the hospitals at all, except for the clinical team. There were travel restrictions very early on, and actually we gave letters to our staff so that should they be stopped by the police, they would be allowed to continue on their way. And several of them were stopped, particularly early on after the executive order when traveling in the middle of the night. And commuting became difficult. We are a city OPO. We travel a lot by subway and train. And that became quite fearful for everyone trying just to get to work. We kept our call center and our preservation unit on site initially because we didn't at that point have a plan in place that was actionable to really get our call center mobilized. And our preservation remained on site with a backup plan to move should we need it. The biggest concern about the preservation unit was whether our office building would close. That was actually designated essential, so we knew then we were safe. But we do have a backup plan to relocate if we needed to. What we did find, though, was in all of this that the human resource component of the organization was key. And the support we had from my HR VP has been incredible. Typically, we think of HR as the office down the end of the hall where you go when you want to post a position, and you forget all the other work that they do in looking after the welfare of your staff. And this became vital very early on. If you recall, there were daily changes to CDC mandates as to who wore a mask, who didn't wear a mask, what the PTO or sick time rules would be, who could apply for childcare. Every day was a moving target. And like many of you, we had a lot of sick calls, and we had to differentiate those sick calls between what was COVID and non-COVID sick calls, because the rules were applied differently in different situations. So we ended up having a lot of staff go in and out. We have a staff of almost about 170 people. So as you can imagine, people do get sick. I myself was out too early on. And tracking all of that became key. So we set up a central tracking SharePoint file where we could know who was out sick, who needed help, who was coming back. Also, the severity of the disease was important as well. We did end up, or we have to date, have 3 staff positive for COVID. They are all well and back at work, thankfully. However, many of the staff have lost loved ones, and so we've also had to allow time for funerals as well. Our human resources component didn't stop with our onboarding program either during this time, and we've moved our education and training platform to completely virtual and have been successful in orienting new staff. We also, at the same time, had staff that changed their mind about coming to work with us once COVID hit full throttle, heading to New York. Good idea at that point in time. We ended up looking at our IT department very, very closely. We needed an IT solution to get our call center home. That became very clear. And if you imagine getting 75 office staff to work remotely, that's a lot of computer equipment. We clearly didn't have substantial supplies, but that did result in our director running down the corner and buying laptops so that we could then install the appropriate software and follow staff home so that we could get them all to work remotely. And we were successful at doing that around about March 23rd. We also had to re-engineer our phone system. We do have a backup phone system with Statline, but that was quite clearly not going to be an option, as Statline is a backup for many of us. So with a lot of creative thinking, we were able to resolve those issues. Our community services went straight to work from home, but clearly there's no community activities going on. So we increased our social media presence, and through our volunteers, we stayed connected with them as well and set up Zoom meetings for all of our TRIO support groups so that they could stay connected with us through all of this. And we do wellness checks on our volunteers as well. Our donor family services continues today, and that is all done remotely. We actually do our own grief counseling, and we have continued that work through Zoom as well, so that our families and our donor families can continue to feel supported. I wouldn't underestimate, though, the stress of your team. Very early on, this was very, very clear that everyone was very much afraid. We didn't know what we were going to find in our hospitals. The press was outrageous many of the time. And we traveled by subway, so that transportation modality became a problem for the staff. So we ended up bringing all of our staff in, those that had to come into the office by subway. We changed that to Uber or to car service so that people felt safe, particularly our preservation unit was still working on site. And they really became the hub of our supply chain as well. But the state of our hospitals, the massive surge so quickly. If you recall, in March 5th, we only had 44 patients tested positive with 44 tests with only 22 positive patients. Now we were seeing hospitals at 200% surge capacity. So staff became concerned about their own safety and what exactly would they be bringing home to their own families as well. Next slide. So moving to a virtual OPO actually was easy. It was the rest of it that was hard. And I like this slide because it really shows graphically what happened to us in New York. You can see on the blue line, those are the usual referrals and the increase in the referral volume. Like many states, we have a routine referral law that requires that all deaths be reported to the OPO for organ, eye, and tissue evaluation. We were seeing many more deaths than what was being reported in the news because the news was reporting COVID positive tests and the testing was limited early on. We were seeing all deaths. And you can see that very quickly the call volume became incredibly large and very difficult to manage. The green line at the bottom shows out of all those calls, how many of those were organ referrals. And we would typically see on an average day about 75 to about 110 referrals a day. 30% of those referrals are organ referrals. And you can see here how our referral base has just dramatically diminished. We typically follow 30 to 35 cases a day with about 30 to 32 organ donors a month. And now we're lucky to follow 4 cases a day. Next slide, please. So how do you redesign best practices? The one thing I've talked about here with my staff is there are no best practices in a pandemic. Everything that you thought about as an OPO that you were doing, every lecture you went to, everything now has become reversed. And what I mean by that was we really had our clinical operations. So we like every single phone call coming to us. We want to hear of every death. We want a timely referral. We want to be able to audit all of that. Well, when you're trying to manage 600 phone calls, that intake process became a need for change. So we had to change that quite quickly to something that was very, very quick. And early on, we learned to change to either COVID or non-COVID right up front so that we could get the provider off the phone. Following that, we had to make a decision. Usually you'd like to go on site for every single referral. In this case, it wasn't going to be practical. So where we had access to EMRs, we followed our cases remotely. We still called the units, spoke to the staff. We got a sense of what the plan of care was, but we made sure we were clear on our plan of care before we deployed anyone on site. We do go on site for areflexic cases that are being declared and for any family conversations. But the rest of the time, we are following those cases by phone and through our remote access. We needed to have that clear pathway just to be sure of what was the outcome going to be in this particular case. We also wanted to make sure that our authorization to OR times were quick. Very often we were asked, please do not delay the case. This is not a time when we could sit for 2-3 days doing testing, trying to run through lists. It was very clear to us that hospitals were asking for the ventilator back. They needed the bed back as well, desperately. And so when we did get authorization for organ donations, we made a very clear path from the testing that we needed to have done to when we would get to the operating room. We also had to secure a safe place for the donor. Many of our units were now becoming 100% positive. as are some of the hospitals. And so finding that safe place was also key. Quite often we're able to hide in PACU or in a corner or in a room away from the rest of the ICU, and that has been very helpful for us. Early on March 14th, we decided that we needed to do COVID testing. We have a fabulous infectious disease group that works with us. We called them to an urgent meeting on a Saturday morning. And so we made the decision then, because we had access to the Department of Health testing, that we would test all of our donors. That has since moved over to testing with Mount Sinai and NYU, mainly because they were gracious enough to give us access, and they have rapid testing, 8 hours turnaround for both of them, and NYU also has 45-minute turnaround. That has since changed. We've changed our process. We do test initially, and then we make sure that we test within 24 hours of the OR as well. One other change in clinical was the need for PPE. Most OPOs, we don't carry N95 masks. We don't typically need them. They're rule-outs for organ donation, but now our staff needed them to feel comfortable on those units. So like everyone else, we purchased a lot of PPE and then had to ship that out to our staff. We also needed to have our recovery surgeons ready to recover for us so that teams didn't have to come into our DSA. And initially that can be problematic, especially for thoracics, but they're able to do that. But now we're finding that the surgeons that we rely upon are either sick or have been redeployed themselves and are not always available to us. And as we ran into problem solving with different areas of the support mechanisms, we came across many other challenges in how we manage our day-to-day. So the call center management was now remote, but severely stressed with all of the phone calls they were taking. Many were listening to staff who were distressed on the phone, but some even told us, thank you for what you're doing, because at least you can save lives when we can't. And that really kept the morale of the staff going. We ended up redeploying a lot of our hospital development staff. Anyone who had previously worked in the call center went back to working in the call center so that we could have enough staff to manage those phone calls. And the other thing that we needed to do, and this is completely against any best practice, was we told our hospitals that they no longer had to refer COVID positive cases to us. The providers were asking us to make that decision. We were asking ourselves to make that decision. So once that decision was made about 8-9 days ago now, we finally saw the volume of calls reduce, both with the reduction in some of the deaths, although we've plateaued, but really now we're seeing cases being called through to us as that message has gone out, and we're better able to manage the volume of calls. Our donor management has changed. We have to be very clear on what testing we need. We have already changed our COVID testing, as I discussed. We make decisions whether to do liver biopsies or not. We may move them to a liver biopsy in the OR rather than doing pre-liver biopsies so that we spend less time on the ICU. On the other hand, we may want to do a liver biopsy so we can rule a case out sooner and not continue a case if there's no organs placed. Getting a bronchoscopy is really tough. The pulmonologists really are reluctant to do a bronch in the presence of this disease, even if our donor is COVID-free, they still do not want to do a bronchoscopy. We're able to get CTs of the chest. Cardiac cath is somewhat hit or miss, depending upon whether those units are closed or open. And organ allocation has become for us extremely difficult. Many of our transplant centers are limiting who they are transplanting. They have limited resources themselves in the transplant centers to perform a transplant. They have providers who are sick and are really only looking at taking those cases that are extremely sick. And we've also been told, when we've exhausted the list so many times, that there is a general reluctance to take any organs from New York City. Our hospital services department is now fully remote. There are no donor councils, no education. They are helping us with the clinical teams. We do virtual rounds, keeping up with our champions. We're able now to do more with them. At one point, it did totally shut down. We did have 8,000 new beds come online in New York City. None of them actually really have filled to capacity. And in fact, many of them now, because we've plateaued, are actually starting to be shut down, which is a good thing. Where the health systems manage the field hospital, the referrals have continued. Where the field hospitals are managed by the federal government, we have not seen referrals from those particular institutions, nor did we expect to, given that none of them were taking ventilated patients. Our family conversations are no longer face-to-face. Many of our families have not been permitted to come to the bedside even when their loved one has been dying. And so that has forced us to have our conversations by phone, and for sure is not a best practice. Although one family told us last night that thank you for calling us because you've restored our hope in humanity for allowing them to give consent for organ donation. We do have a rapid response now to challenges very early on. Our transportation systems failed us. They equally stopped working. Ventilators need to be returned. We've got scarce supplies. There's a shortage of swabs to do COVID testing. There's a shortage of IV meds. There's a severe shortage of dialysis fluid to be able to dialyze anyone right now. And we relied heavily throughout all of this on our internal and external communication plans. I hold a weekly town hall meeting with my staff. We have daily emergency management meetings with the leadership team, and frequent communication with my medical advisory board and also the board of directors has been vital as well. But external, this group has been outstanding. To be able to communicate with New York State 3 times a week has helped us tremendously deal with many of these issues. Greater New York Hospital Association is also another partner. We're members of our hospital association, and that gives us a direct link into the emergency management for New York City and the state. So when we've needed supplies, they just supplied us with 1,000 N95 masks. We're able to get access directly to them. And with my CMO, Dr. Friedman, and we've been sending out updates to our CEOs and our CMOs directly, reminding them that we are still here and to still call us. So one of the things that's been of great benefit during all of this and to help with our staff, and is something I hope continues afterwards, is we have developed a program called Live On New York Cares. And Live On New York Cares is really about the staff. And so we help them by providing opportunities to meet and talk to each other. Yes, we do have a social hour at 5 o'clock on a Friday, but we also do online yoga, online meditation. We have virtual recess for the kids. We have access to a chaplain and a rabbi who are giving one-on-one support for any of our staff that need it as well. So we still are very passionate about our mission. We will not lose sight of our mission going through all of this. Every organ, every patient, every time still matters, but the safety of transplantation and organ donation matters, and the safety of our staff matters. And with that, I'd like to end my presentation and introduce you to Bridget Sullivan from NYU, Dawn Freskowski from Stony Brook, and Melissa Porter from Northwell Hospital to be able to discuss with you their journey.
Thank you, Helen. Thank you for a great presentation. I'd like to start by thanking all of my New York Transplant and OPO colleagues for their incredible support during this time. It's been amazing, and particularly Don Francischini, who's the transplant administrator at Stony Brook, and Donna Campbell, Colleen O'Donnell, and Melissa Porter from the Northwell system, and I'll hand the second half of our section over to Melissa. We collaborated closely on this section. So first, if you can go to the next slide, I'd like to share some data to give perspective to the situation at a transplant hospital. This is my hospital's data, NYU Langone, but hospitals in our area have very similar experiences. On the green and red graph on the left is daily new admissions to the NYU Langone main campus hospital. Red are the COVID positive patients, and green are all the other patient admissions that are not related to COVID. And you can see how very quickly our hospital was taken over with COVID patients. On March 17th, we learned that one of our transplant surgeons was quite sick with COVID symptoms, but testing wasn't yet easily available, so we couldn't confirm that he was in fact positive until almost 10 days later. But within 24 hours of him reporting feeling ill, we found that 3 transplant patients who were in the hospital were exhibiting severe symptoms, and the numbers of patients admitted with COVID really started sharply increasing on March 20th. On March 26th, we opened several additional areas to house patients, including previously closed inpatient wards, outpatient clinic spaces, and even ICU beds were particularly needed because of the need for ventilation. And in less than 2 weeks, we increased our ICU capacity by 119 beds. Fortunately, the COVID admissions have now leveled off and they have started gradually decreasing, but as of this morning, there are 423 COVID positive patients in our 750-bed hospital, and 144 of them are intubated, so it's still a very serious situation. With the huge influx of the COVID patients, there were also significant mortalities, and you can see that in the lower left-hand corner. So we really had to make some difficult decisions about whether or not to proceed with transplants, not only because there was a very limited bed availability, very limited COVID testing available, and staff was decreasing because they were ill with COVID symptoms, but also because it would be very dangerous to subject a newly transplanted patient, particularly in the time when they're very highly immunosuppressed, to such an infectious environment. So therefore, we, as many of our other colleagues here in New York, had to implement a strategy of assessing the risk of COVID infection to a newly transplanted patient against the benefit of transplant. Our rule of thumb was if the risk of mortality related to COVID-19 was greater than the risk of mortality without a transplant within 3 months, which is a time frame that we expect the COVID outbreak to last and really settle down enough to be safe, then we would not proceed with the transplant. Can you go to the next slide, please? Living donation cases that have been scheduled also had to be carefully considered. Initially, we believed that we could preserve a safe pathway for the donor and recipient. However, in the initial week, some centers reported instances where patients, donors, and recipients contracted COVID in the hospital shortly after surgery. So we decided to put living donor cases on hold. And now there's suspicions that insufflation, or the air release that happens during laparoscopic procedures, is a concentrated source of the virus and should be avoided, so this may have contributed to those early bad outcomes. For those patients on the waiting list, only those in the highest acuity statuses, so heart status 1 or 2, lungs LAS is greater than 80, and liver MELD patients with MELDs greater than 35 were the criteria we used. And only kidney patients with limited opportunities for donor organs, like very complex antibody profile patients or patients who had exhausted vascular access, remained actively considered. At NYU, we had a status 1 heart patient, and we were able to transplant him in the new environment, but after that, only a handful of patients have remained active and are actively on the waiting list and being considered for transplant. It was important for us to make the patients who were not going to be considered for offers inactive so that the OPOs weren't wasting time trying to allocate organs that we were not intending to accept. So we took the approach of individually inactivating each patient in UNET, using the COVID-19 precaution inactivation reason that UNOS released on March 17th. This was our approach, but it's also possible to tightly restrict your donor acceptance parameters in UNET, particularly donor age, and making it 99 years or older to prevent donor matches for any of your patients. We organized our staff who were working remotely to call each of the 956 patients that we had on the waiting list to inform them of this inactivation. We also sent a letter explaining the reasons for the inactivation to each patient, as well as to the dialysis units of the kidney patients and the referring physicians of all of the patients. To date, every patient who was informed of this has been very understanding of the precaution. We also have had patients who remained active turn down offers because they didn't feel comfortable moving forward with transplant in this environment. Now I'd like to transition to Melissa Porter from Northwell. Melissa?
Thank you, Bridget. So yes, my name is Melissa Porter, and I just wanted to thank this group for this wonderful forum to share our experience of Northwell Health. And I truly hope that it helps our colleagues around the country. Communication to both our patients and staff was and still remains our top priority. We ensured that our multidisciplinary team identified COVID positive cases, and we shared our frequently asked question sheet. Each one of our post-op patients that was within their 18 months of transplant received a call from their coordinators. All of our living donor pairs were reached, whether they were in their evaluation phase or still scheduled to be seen. We also remained in contact with all of our longer-term post-op patients to ensure open lines of communication. To no one's surprise, our list of patients also became noticeably anxious, and we had our waitlist coordinator continue to contact them in an attempt to settle their anxiety. And while making these, several patients commented that they appreciated the call. Despite our numerous redeployments, we were able to identify specific at-risk groups to be contacted by our social workers, nutritionists, independent living donor advocate, and/or our pharmacists for assistance. For example, if we knew that one of our patients had a history of substance abuse, we arranged for our social worker to contact them immediately. In March, as the COVID positive case number began to steadily increase, we knew that updating our website would be of great importance. We found that an early and strict message was effective for several weeks. We ensured that our program coverage plan was provided, and this plan requires for us to give any written communication to our patients, referring physicians, and other clinicians that would require the information. This plan was posted on our transplant-specific website, in addition to the health systems website, to ensure ease and transparent communication across all of our 22 hospital sites and 77,000 employees. We thought it was possible by any means. Our transplant-specific frequently asked questions tip sheet, which will be shared as a handout during this presentation, was also proven to be a helpful tool. System-wide communication was a constant and evolving focus for our health system. Just as a reference, we are that small boot of an island on the image of New York, and our 4 transplant program serves over 8 million people. So constant communication regarding PPE, guidelines, and requirements was being sent several times a day at points. As time passed, it was overwhelmingly obvious that our staff and employees needed assistance too. Therefore, the Employee and Family Health Services was a resource broadcasted and strongly encouraged for all to use. This service was free to any employee that felt overwhelmed and/or just experiencing difficulty dealing with the stressors of this unprecedented time. Each day that passed, we found that starting by doing what is necessary often led to accomplishing the possible, and then we found ourselves being able to do what we considered impossible. And with that being said, just this week we celebrated over 1,800 COVID positive discharges at our transplant centers, hospitals. Next slide, please. Leading us to arranging phlebotomy at home. Our LabFlap program has existed for some time now, and it is a Northwell-based app that allows our patients to schedule their lab draws at their leisure. The appointments are based at a time slot availability, and it is a small fee associated of $20. But looking at our transplant-specific patient population, we realized that there was a more specific need. And once again, it was our time to attempt the impossible. So we worked with our core lab partners and quickly developed HomeDraw. Now, this is a service very similar to LabFly. However, given the new requirement to remain socially distanced and homebound, now the fees would be able to be submitted directly to the patient's insurance, and we would be able to utilize the already existing provider or entered orders to our lab partners to contact the patients directly and work out a specific lab draw before 11 a.m. on the specific date and location of the patient's choice. Thus far, we have had a positive response from both patients and the providers, and we look to continue to. Now, although this chapter in our story is not yet complete, it always seems impossible until it is done has become a mantra often used by our team. I wish everyone good luck, and I thank you. Now I will turn it over to Diane Woodrow of Mount Sinai Hospital.
Can you guys hear me now?
Yes. Great. Keep going.
Thank you. Sorry about that. All right. I'm from Mount Sinai Hospital. I'm the director of the Living Donor Transplant Program there. And I want to share with you some strategies for continuing to do transplants during this pandemic, but really trying to create a safe environment for us to be able to do that. So if you can go to the next slide. We have one of the longest kidney lists in the state. And we have a lot of high meld liver transplants and have the ability to do all abdominal organs. And so we had to really think about what we could do in this pandemic to try to stay open as long as possible. And in March, when CMS designated transplant as a Tier 3B essential surgery, similar to trauma or vascular surgery, kind of the highest level of surgery, we met with our hospital senior leadership to try to figure out a way for us to stay open and perform transplants in a very controlled situation for as long as possible. And I think that we would never be able to still be doing transplants today if it wasn't for the commitment of the hospital and the whole health system. I mean, we are fortunate in that our CMO is a transplant ID specialist by trade, and so understood COVID, understood the environment, understood the hospital environment, but also understood transplant and transplant immunology. And so it really helped us to be able to do this. Next, you needed to have team buy-in. As some of the previous speakers were saying, the rules were changing every day in terms of how the virus was spread, what precautions you needed to do, what meds potentially could work. And so you really needed to make sure that you met with the team, that we discussed everything, and that the team remained flexible and really understood what our main goal was, which was to try to safely weigh the risks and the benefits and perform transplants in a safe way. We also needed the patients to trust us and to be willing to proceed. And not everybody wanted to go ahead, but we needed to be able to convey the facts to the patients' referring physicians in a way that they understood and help them be involved in the process of deciding whether they themselves were going to go forward with the transplant. And then we also needed to have flexibility because we would put a plan in place and 3 hours later it would need to be changed because of a new information or something that happened. And so the rules changed continually through the whole process, and we all needed to identify that this was dynamic and what was true today may not be true tomorrow. And so with that, we'll go to the next slide. So we broke down what was needed in a bunch of categories so that I can adequately explain it to you. So first of all, we needed to have space to take care of the transplant patients. And so Mount Sinai Hospital is fortunate in that we do have a designated transplant unit, a floor with private rooms with living donor suites, and we also have a designated transplant ICU, and that is a negative pressure unit. And so at the beginning, we were able to perform the transplants and have our patients housed in these designated transplant units where none of the COVID patients were being placed. But by March 30th, it was impossible for us to keep the transplant ICU as a COVID-free unit. And in fact, it was needed to put COVID patients in. And so then we had to be resourceful. And we met with hospital leadership. And many of you who know Mount Sinai, it's a very large health system with a lot of buildings on a lot of different streets within Upper Manhattan. And so we were able to move the transplant ICU to a virtual transplant ICU in the Annenberg building, which is a building that typically doesn't have a lot of patients. And it had an old PACU in it that was used for pediatric surgeries and some kind of minor ambulatory type surgeries. And so we were able to convert that unit into a virtual transplant unit. We called it COVID negative, not COVID free, because again, you were not testing every single patient. You were testing patients at various points during the procedure, but again, it was a COVID negative unit, and once patients became positive or had suspicion, they would be removed. But essentially, it has remained COVID negative, but it was the goal was to keep it that way. It was never called a COVID-free unit. We also had this med-surg unit, which then had to be moved to a different, smaller unit as the number of transplants went down. And we have COVID negative operating rooms. And so the operating rooms are rooms that are only used for transplants, and so no other patients go in there. And so if we could use this space the way we had designed it, we felt it was relatively safe to proceed. Initially, when we talked about testing, we tested donors and candidates just by screening of symptoms. However, we were able to get the testing at Mount Sinai fairly early in the process, and currently all deceased donors, living donors, which we're not doing currently, and candidates are screened and tested within 24 hours of surgery. And then on the floors, the med-surg floor where the patients are recovering, if any patient develops symptoms of COVID, they're immediately tested and transferred if they're positive. As of March 30th, we had to make some specific staff changes. And so when we had our virtual transplant unit developed, it was staffed 24/7 by liver anesthesia physicians. So it freed the other intensivists in the hospital and ICU teams to take care of the COVID patients, and our liver anesthesia medicine physicians ran our ICU. And then they needed help, and so our RMTI physicians, the nephrologists and the hepatologists, also were assigned to the units to take care of these patients. And so it was a true collaborative initiative by anyone who was involved in the transplant care. Usually our transplant ICU has a 2-to-1 nursing ratio, but we couldn't do that at this point. We changed it to 3-to-1 with a few caveats. I mean, there were a few chronic patients that you could justify having them 3-to-1. And then depending on the acuity of the unit, how many fresh transplant patients in it, some nurses did have a 2-to-1 and others had a 3-to-1. But we brought our transplant coordinators, nurses and Ps who were typically taking care of outpatients, and had them assigned to the unit on a rotating basis as well to help. And so this helped to alleviate some of the stress and really ensure that the patients got the care they were needed. I know myself even did a few ICU tours, and it actually was very useful because not all of the critical care nurses in the unit were familiar with transplants. And so having the transplant coordinators there understanding this and understanding all the nuances of the patients really ensured that the care was as good as it would have been had we not been in this COVID situation. We also deployed our medical assistants from our outpatient practice to help care for such patients. And so this was the way we were able to make sure that the staffing was appropriate for the patients. When we looked at the types of patients we would transplant, we couldn't transplant every patient on our list. And so we had to look through and really decide who were the patients who had increased risk of mortality and really should move forward during this pandemic. And so with the liver patients, we selected patients who had a higher MELD. Often they were inpatients who had complications and then ended up being hospitalized, or those who were sicker than their MELD and were at home. So someone who required large volume paracentesis on a regular basis or was very encephalopathic. And then for the kidney patients, we didn't do any preemptive transplant patients. These patients had to be on dialysis because they were being exposed and at risk of getting exposure to COVID when they go to the dialysis units as well. And if we tested them negative, we felt that it was appropriate. We also picked patients with minimal comorbidities. Now, on call at night was very challenging for the transplant coordinators because you did have to go through the list to select these patients, but also once you found a patient you felt was appropriate, you had to spend time educating them. And there were many patients who refused to accept the organs, and so then you had to go on and try to find somebody else for the organ. So it was challenging, but it was also a necessary thing and worth it. When we looked at the types of deceased donors we would use, we picked standard criteria donors. They were early on, cause of death was non-respiratory, and then once we were able to be testing, it was COVID negative. Our local kidney volume is low at this point, and I know Helen has alluded to that earlier, and many of our livers are being imported. And when we do import organs, we are trying to get the local centers to do the procurements when available so that we don't have to send our teams flying to other places. And most times we've been able to accommodate that. Unfortunately, at this point, our outcomes are very good. We've had really good results. We did have one liver transplant recipient contract COVID after surgery, and this was identified on the day that they were supposed to be discharged. They developed a cough and then was tested, and they were COVID positive, and that person remains in the hospital. But this person actually had their surgery before both the donor and the recipient were being tested. Since we've done the testing, we haven't had any patients at this point develop COVID.
Well, thank you. So my name is Daryl Blackstock, and I am the Director of Clinical Transplant Operations here at New York Presbyterian for the Cornell and Columbia campuses. And I have to say, it's nothing like starting a new role, which I did March 2nd of this year, and facing a worldwide pandemic that was coming to us in, I would say less than a week. I learned the importance of great partnership, not only here at New York Presbyterian within the Columbia and Cornell campuses, but also throughout the state, and with our esteemed colleagues that are present on this phone, as well as those who participated in our on our calls each week. So our approach to managing the patient outside of the center really it fell into three categories. The first was, understanding and closing the, knowledge gap. The next was, telecommuting, enacting that. And then finally it brought us to a place where we can really provide some great telehealth results. So as you see on this slide, what did we do to close the knowledge gap? Well, we had to identify what was known and not known with this novel coronavirus that causes COVID-19. We had to then educate ourselves and educate our patients. I included, fact sheets that were sent to our patients both in English and Spanish. And it's important to note here that we attempted to close the healthcare disparities by including information in Spanish, and I urge all centers to do so, because later information produced by the city showed that our Latinx communities really suffered the brunt, followed by our African American communities. So please, be cognizant of paying attention to your healthcare disparities. I didn't forget recognizing our own personal and professional limitations. What do I mean by that? COVID really forced a lot of us to practice or address concerns outside of our normal practices. These patients presented with a whole slew of symptoms, primarily airway. So we had to recognize that and again, educate ourselves and prepare ourselves. And then personally, how are we going to deal with this? We heard from Helen Irving that, providing that emotional and well-being support was extremely important. Next slide, please. So next is in managing the patient outside of the center, if you can, just to the next slide when you get a chance, is the telecommuting piece of this. So when Governor Cuomo issued the state of emergency and the subsequent stay-at-home social distancing, and saying that your your staff members who are not patient-facing really should telecommute, that gave us a challenge. We had to first assess the technological needs of our patients and our team members, and thinking through with our team members who had students living in the home, they were also told to stay at home. They would also need to, use the technological equipment that they had at home. So this really provided a challenge. We had to ensure that our teams had VPN access to remotely to our electronic health records. We also had to deal with, from a management perspective, attendance keeping. We use Chronos here. We had to make sure that electronic missed punches were in place and that people know how to use that. We had to sign telecommuting agreements so that we could add features like timestamps into our staff members' Chronos profiles. Another area that came up is how do we measure staff activity or productivity? So I include an example here where we use a transplant staff work effort. And as you can see, it tracks phone calls, types of tests that are ordered, and notes that are written. Other types of metrics were daily huddles that we would do twice daily. We would also use a program called Qualtrics, which is primarily used as a survey, but you can also use it to manage projects, which was extremely helpful. And then WebEx accounts or things like Microsoft Team meetings and Zoom became extremely important for team meetings, team selection, donor selection, transplant initiative, that's your transplant-wide meetings, and individual program meetings. Next slide, please. Then we come to telehealth. We were fortunate here that NYP had already been investing in telehealth, although we hadn't embraced it as much in the transplant population. So we had to do that in addition to embracing a new EHR system. We went live with Epic at Columbia in January of 2020. To do telehealth, we used different devices such as laptops, iPads, iPhones. We did that with the resources from the health system as well as personal devices. We worked closely with our IT team to make sure that we had secure access to the remote access to the hospital system. We also conducted patient-facing education, giving out simple one-page summaries to patients, in addition to accessing the healthcare system's education material that they already had in place. And we did some test visits with some of our tech-savvy patients who, were very comfortable. So we were able to test the system and fine-tune it. We did the same for our team, education. So this would be our providers, our coordinators, administrative staff that would be conducting these telehealth visits. We made sure that they had the proper applications downloaded. And we also tested the functions, which was extremely important. How do you look on camera? How do you come off on camera? Is the lighting correct? Are you having it, geared towards, because emotional intelligence here is extremely important. Because we are a group that we like that physical contact, that face-to-face, and now we had to do this over the internet and over some piece of technology. So we had to make sure that we were still emoting and still connecting with our patients. So I wanted to share with you a successful sequence from one of our programs when conducting telehealth. So they, of course, did test visits with the patients. Next, they had administrative assistants call the patients to make sure that they had access to the patient portal, that they had an email address, and that they were comfortable with using whichever device that they were using to communicate with us. After we had that initial setup, then we would have transplant coordinators, our social workers, financial coordinators, conduct another visit with the patient. So at this point, the patient was becoming more comfortable and acclimated with the telehealth or patient portal, so that when we got to the final stage of a visit with our physician and surgeon, that it led to a much more richer interaction where both parties felt, comfortable, and the patient felt as though they were all needs were met. And so the type of visit that we were able to do were our donor and recipient evaluations, our post-transplant visits. We were also able to conduct general education modules. And I'll say from our lung program, they worked closely with our physical therapy department to put together physical therapy or exercise demonstrations so that, especially in our pre-lung transplant populations, that they were able to continue some of that the exercises, which is extremely important to their survival post-transplant. Next slide, please. So what have we learned? It's extremely important to over-communicate. And before I go on, let me just point out that we're fortunate to have some of these sidewalk art around our hospitals here in the city. And let me just read this to you. It says, "Alone we do so little, together we do so much." And it's all about teamwork. I mean, that's just been the theme that I think you've heard from all of my fellow presenters, and that's the same sentiment that I'm echoing now. Other things that we've learned, enact your command center early to streamline communication, embrace innovation, as well as get to know and appreciate and work well with your IT team. The effects of social isolation, and the importance of emotional intelligence. Again, it's not just for the patient, but it's also for your team members. Understand that, we spend the majority of our time here at work, and so we're going to miss those relationships. So it's extremely important to pay attention to that. Practice understanding patients' mental health, again, for your patient, as well as team members. And assessing technology needs to be done early. Where are we now? We're still embracing what's new and unknown with much more enthusiasm, I'll say, because we're more comfortable in this space. Managing the anxiety of stress, again, in your patients, as well as in your team members, and constant knowledge sharing. Next slide, please. So again, just wanted to wrap up with another piece of sidewalk art. Thank you for fighting. It says here in New York City, but I have to tell you, New York State, the world, the United States. So thank you. And with that, I'm going to turn this over to my colleague, Eileen Farrington at Westchester Medical Center. Thanks again.
This is Eileen Farrington. I'm the Senior Director for the Transplant Service Line at Westchester Medical Center. Just to give some perspective to the non-New Yorkers, Westchester is located about 30 miles north of Manhattan. So we focused a lot this afternoon on communication with each other, with patients, with regulatory bodies, and how we've quickly had to reevaluate how we work, where we work, and how we can continue to care for patients during this time. We also thought it was important to share some insights from the hospital perspective and some of the things that we have learned. So it goes without saying that a major part of dealing with this pandemic focused around preparation and education. The education component was a heavy lift, not only due to time constraints, but also due in part to the size and scope of the workforce. Just a few of the ways in which education and information were rolled out included frequent emails from senior leadership directed to all staff, making note that the information being delivered was pertinent not only to clinicians, but all staff in the organization. Getting our nurse educators and clinical nurse specialists out into the units to provide education and hands-on training for staff. Videos and self-learning modules were created and uploaded to the hospital intranet so that education could take place any time of day or night. One of the challenges voiced by our educators was the concern that a combination of fear and/or anxiety could potentially affect the staff's ability to retain some of the information they were being instructed on. More so that this particular information and education could potentially save their own life by keeping them safe, or possibly impact the lives of those patients they will be caring for in the imminent future. Another challenge lay in the reality that nursing staff, no matter their previous experience, would be caring for critically ill patients at some point. So while all this education was being rolled out, and the number of patients rolling in began to climb, it became clear there were many things we knew, but many things we knew weren't always right, as we've learned. I guess a good example of that would be our original ventilation protocol. Early on, it became quite apparent that despite similarities in factors such as patient age, presenting symptoms, even radiology, these patients did not all respond the same way that clinicians would have expected them to when receiving the same or similar types of ventilation management. This resulted in changes to clinical practice guidelines, and as you could expect, created some confusion early on. Now, in hindsight, most would probably agree the educational resources were thorough. I think most would also agree we should have begun sooner. While we all knew what had happened in Wuhan and were watching the events in Europe, I think many were still in denial that the pandemic would affect us on that kind of scale. And so as part of this enormous undertaking, the first of what would be many drafts of the Coronavirus Disease Manual was created. Next slide. So in order to provide guidance for both operational and clinical practices, COVID-specific protocols were implemented, as I just mentioned. Protocols dictated which staff members received which type of PPE and the frequency at which they would be replaced. This was one of the many protocols that was revised several times as new guidance became available. Plans for the designation of COVID-positive units and the creation of additional ICU beds began. As you've heard, most of the transplant programs attempted to maintain COVID-free or COVID-negative, I think Diane actually just said, so I'll refer to as COVID-negative inpatient units. But as you've also heard from most of our nursing colleagues, unfortunately that proved to be impossible for nearly all of us. Almost, if not daily, patients in those COVID-negative units were testing positive, making the sheer volume difficult to maintain even one COVID-negative unit. In early March, screening stations were set up at all points of entry to our hospital. All patients and visitors entering the building underwent temperature checks and were asked questions specific to signs and symptoms for COVID-19. While visitors are not currently permitted in the hospital, screening continues for staff when they arrive for work. In accordance with CDC guidelines for patient management, numerous clinical protocols were established. And while I won't take time to go into them today, I've listed several of them on the right side of the slide here. Next slide, please. Our hospital set up large tents and began on-site COVID testing for patients and staff on March 17th. Within 4 days, this service was made available to the public. Protocols for testing both symptomatic and asymptomatic staff with a confirmed or suspected exposure were implemented. Results for employees are back within 18 to 24 hours and within 3 to 4 days for the public. A rapid test providing results in 1 to 2 hours is done for symptomatic employees with comorbidities and for all inpatients. I think that not only has this testing provided peace of mind to many, it has been helpful in allowing staff who test negative to return to the workforce once they're feeling better. Just to give you an idea of sort of the size and scope of the testing that has gone on, I don't have this week's numbers, but as of last Saturday, the center had received over 20,000 phone calls and had tested over 12,000 patients. So in an attempt to support the workforce during this very stressful time, the hospital also implemented a confidential 24/7 support hotline. The line is staffed by our psychiatry department and is available to provide support and address issues that staff may be experiencing with anxiety and distress during this time. Additionally, the hospital partnered with hotels in the area who offered to provide low or no-cost hotel stays for those staff who are either looking to self-isolate from their families or who may travel a distance to work and need a place to stay between shifts. During this time, the outpouring of support from the community has been overwhelming. People have offered to help in numerous ways. Food was one of the most popular offers. In order to help organize and distribute meals, our marketing department implemented the use of an online service called mealtrain.com. The platform allows for vendors to create an account and sign up to provide meals for the staff. We are currently getting 300 individually packed meals for staff 7 days a week. 150 are served at lunch and 150 are delivered later in the evening for the night shift. Food is delivered to units on a rotating basis. Next slide, please. So transplant-specific preparation. So perhaps one of our biggest challenges has been maintaining some of what I would say, I'm using air quotes, normal transplant operational activity with only a fraction of our staff. In the very beginning, the impact on our program wasn't so bad. However, as the number of COVID positive cases began to rise, affecting not only our patients, but our transplant staff, we knew we had to make some changes. As I mentioned earlier, the hospital was providing on-site COVID testing beginning in mid-March. Almost all of our non-clinical support staff had been deployed to assist in those efforts. And the few that remained in our transplant program took on additional responsibilities and did what they could to cover the service. Contingency plans had been developed and were implemented on or about week 2. Our clinical staff was divided into 2 teams. Team 1 worked on site and were responsible to round on the inpatient service and see any patients in the office. The use of telemedicine also started to ramp up for us as the weeks went on, as the clinicians didn't want patients traveling for visits that weren't absolutely necessary. Team 2 worked remotely, responsible to take care of day-to-day operations that didn't require on-campus presence, such as prescription refills, following up on labs, contacting patients, and those types of activities. After a week, Team 1 worked remotely, and Team 2 came on site. This was done in part to decrease exposure to patients who were known positive, as well as those who may have been asymptomatic and as of yet undiagnosed. Not a month in, though, it was clear that the inpatient workforce needed additional resources. At this point, the transplant coordinators were deployed to the inpatient units to work 12-hour night shifts. This was no doubt a very frightening thought for all, as many had not worked on the inpatient units in well over a decade. And new technology, EMR, Pyxis, lack of access to med rooms and supply rooms created additional challenges, not to even mention the physical work and staying up all night. Despite these challenges, the coordinators have really stepped up, working collaboratively to cover for each other while providing much needed nursing assistance to their patient colleagues. I'm truly grateful to their commitment. And finally, communication. With the rapid pace at which things were changing, and with the team scattered, quite literally, we knew we needed to maintain regular communication to the staff. Daily debriefing teleconferences were scheduled for late afternoons to provide updates, both specific to transplant, as well as anything related to what was going on in-house. On the days of the consortia calls, I made sure to provide any new updates or challenges our colleagues in the city were reporting to let our staff know we were all dealing with similar issues. Just last week, we changed the frequency of our calls to Monday, Wednesday, Friday, and the information we're sharing isn't that much different from call to call. Just this week, there have been a significant decrease in the number of new cases. The volume of rapid response calls seem to have decreased over just the past few days. And we've seen some early success with the use of convalescent plasma in our transplant patients. So dare I say that maybe we're on the far side of the plateau? I'm not sure I'm quite ready to do that, but I remain optimistic. And now I'm going to turn it over to Laura Butler from Montefiore.
But thank you. And I want to echo everyone else's response in saying that this has been an awesome experience to work with other transplant and OPO leaders in New York to share experiences and learn from others. Transplant programs have responded to the COVID crisis by changing the way patients are typically managed in the ambulatory practice setting. It's been a balancing act as we've considered the risk versus benefit to determine those essential activities and who must be seen for face-to-face visits. Our level of activity has fluctuated as team members are deployed or sick, so maintaining continuous communication is challenging but needed to prevent any gaps in care. As discussed earlier, we too are maximizing the use of technology. In trying to balance the needs of transplant patients in ambulatory practice, the level of activity has clearly fluctuated amongst all hospitals, with the increased number of COVID cases on the inpatient side as staff are deployed and to meet the most critical patient needs. We are starting to see that plateau in New York City. Between the 3 Montefiore hospitals in the Bronx, we're still looking at an inpatient census that has plateaued around 1,017 as of this morning. and our inpatient census is still around 90% COVID positive, unfortunately. As an administrator, I've spent a significant portion of my time trying to manage activities based on these fluctuations in staff. The concern for the risk of patient exposure is also a concern for staff, as so many staff have fallen ill. To date, I have had nearly 30 staff who have been out at some point in the past number of weeks. Social distancing, working from home, and wearing masks is good, but certainly not foolproof. Therefore, you must always be thinking of that plan C, B, C, and D. Next slide. Face-to-face visits have been significantly scaled back, and we are currently only seeing those patients fresh out from transplant. At first, it was at less than 6 months out post-transplant, but in the past week or two, it's been more like less than 6 weeks. We are also seeing those with transplant-related complications or those with potential or confirmed COVID-related illness. Other routine appointments are scheduled virtual visits, and patients get labs locally or at home. In clinics, transplants are seen in the AM and COVID patients in the afternoons. Patients are also separated by utilizing different nurses, physicians, and separate clinic space. During the first weeks, if patients called not feeling well, we would work to get them tested. But now we are continuously monitoring at home if possible and bringing them in only if we feel they will be admitted. Patient management meetings are held virtually, and we discuss all new results reviewed and a synopsis of those who had virtual visits, recent admissions, or discharges, no matter how far out they are from transplant. The review of fresh post-ops is something our kidney program has always done well, and now the other programs we're finding are following suit. In a way, this crisis has expanded the use of multidisciplinary team management of post-patients, since we are weighing in on all patients as a team instead of just that one physician or nurse practitioner managing that patient in isolation. During calls and appointments, every opportunity to reinforce shelter in place was done, but also review of when you should call. I know Daryl Blackstock has already gave an awesome overview of telehealth, but to reiterate, the workflow of virtual appointments still requires planning, as patients are scheduled to meet with team members separately. There's an additional consenting process for patients in order to use telehealth, and it has its limitations. Although virtual education has been done one-on-one, group education centers can be done with the higher volume programs in the future. We found that virtual visits to be even more advantageous for waitlisted patients, since these are established patients. Next slide. This is just a slide. The top picture was a selfie that we took. You notice everybody's spread out, but we sent it to one of the nurses that was deployed, and that's what we're trying to do. And it's just showing how we're trying to keep the team positive. And I'm not going to go through this because I know others have done such a good job. But when we talk about war and being in a war zone, a lot of the deployed staff are facing moral distress. And many of them, because of the way patients are typically being treated now, may be different from what they're used to in terms of advanced life-saving measures. They also struggle when they are holding hands with a stranger, taking their last breaths, instead of the loved one that's typically there. So I've listed some things that I find to be helpful in managing staff through this, and I think those personal and team check-ins are an extremely important piece and can easily be accomplished when all leaders in the practice are rounding and touching base. Here at Montefiore, check-ins go to the top of the organization, and the CEO spends 30 minutes each day on the phone with all staff and answers the tough questions about concerns. He's also honest when he doesn't know the answer. Just wanted to mention ASTS also has some great resources in terms of dealing with people in crisis. And we can go ahead and go on to the next slide. In terms of challenges and considerations, because there was a critical shortage in the first couple of weeks, any available PPE was prioritized to be sent to the inpatient side and ERs. This meant that protection was often lacking when you were dealing with potentially infected patients in the outpatient setting. Currently, New York has a better supply of PPEs, and hopefully there are less photo opportunities out there of New York hospital staff wearing those more non-traditional masks or gowns. I want to emphasize, though, that even though it is better, it is certainly still a major issue because many hospitals only have a few days supply at a time. I'm sure this is the case as well in other known hotspots around the country. Also, in regards to COVID testing, yes, there's definitely more of it, but it still has work to do. Some or most facilities still have a wait for patient and staff to get tested. If an individual isn't ill to the point of admission, sometimes they'll wait days to get tested. In terms of exposure risk, the experience in China that has shown patients can be contagious for weeks is definitely seen here. And I'm sure that I've had both asymptomatic patients and asymptomatic staff that have exposed other staff. Since the beginning of March, there have been almost 30 physicians, nurses, and other staff in just a transplant program alone that have been out with COVID. Fortunately, there's been no critical illness. But so in new technology is great, but it doesn't replace in-person visits. Obviously, with pre-patients, you're missing out on the physical exam and better use of frailty testing. With post, New York is seeing more patients die at home. And I just have a question about whether it's because we've focused so much on sheltering in place or people resistant to come in. Also, just want to mention that smartphone is only as smart as the user is to some degree. So if your patients are not savvy, it doesn't work so well. Delays in completing evaluation and listing. During crisis, we've essentially moved the bottleneck of referral to evaluation to the weight of scheduling needed testing. So it will be a good exercise to go back and look at our benchmark data to see what the turnaround is between both practices. And of course, virtual technology is a great add to supplement ambulatory practice, but I don't think it will ever ultimately replace it. Lastly, it is clearly a challenge to manage the stress of others through these transitions without becoming personally overwhelmed, hence the importance of taking care of yourself. Considerations, just a couple of questions I had, and although this has been an experience I wouldn't care to relive, the things we have learned are invaluable to future practice. The future use of virtual visits in all phases of care. As we are still early in the experience of telehealth, maintaining financial viability in the future with these changes is yet to be determined in terms of future legislation, challenges with commercial payers, and reimbursement. So now I'll turn it over to you.
Can you share some of your ongoing strategies for COVID-19?
Wonderful question. Thank you.
Mm-hmm.
Oh, sure. Wonderful, wonderful question. Thank you for asking that. So understand that our current strategies are ongoing. It's ever changing to meet the needs. And so from an outpatient perspective, we're continuing to provide, close follow-up to our patients who are COVID-19 positive. What we've done with Dimitra, who's our Director of Quality Research and Education, we've developed a questionnaire for those COVID positive patients, to gather information about the illness, to manage and assess their symptoms, also to determine if their symptoms are getting better or worse, and then finally to evaluate, does this patient need to come into clinic, or do we actually need to get this patient to an ED for possible admission? Again, thank you for that question.
So the next question was, can you share some motivational and coping strategies that you have employed for your staff? And so I'm really fortunate in that I work at a health system where the medical director or the dean of the med school and the president of the hospital are both psychiatrists. And so I think from day one, Mount Sinai really looked at this as not only a medical issue, but a psychosocial issue. And so there has been staff support throughout the health system. We have town hall meetings once a week where they are present via Zoom and address everything that has gone on in the week. They address concerns from the staff. The staff are allowed to send in questions. And they've also handled some of the media surrounding Mount Sinai and kind of dispelled myths and gave reality checks to the staff. They have a website that's designated to COVID, and there's a whole well-being section, and it addresses all the psychosocial needs of the staff. There's inspirational letters, nice stories. There's a calendar of events in terms of yoga and mindfulness and meditation. There are some virtual support groups. I know there's an advanced practice virtual support group that I can participate in anytime I want. And then there is a place to use to get mental health assessments if you really and truly need some help. You can either get an assessment, treatment, counseling, and then there are also a lot of perks throughout the hospital in terms of food. And Godiva showed up and gave the staff chocolate, which doesn't really mean a lot on any day, but when you've had a really hard day, just a piece of chocolate just kind of appeal to a sense that you kind of needed to appeal to. And so I think that there's been a lot of both transparency and support for us. And I think that that's done on the health system level as well as within the transplant program itself, with managers and teams working together to try to really get things done.
Thank you.
And so I think, Linda, you're next, right?
It looks that way. One of the questions you asked as you were registering was, how did you identify patient needs during the pandemic? So I contacted one of our pre-transplant coordinators, Nikki Lawson, and I asked her what was being done and what had been done and how did you know what your patients needed. And she said communication was the big thing, calling the patients to explain the inactive status, and obviously critically ill patients were not made. Bridget addressed that, inactive. But the kidney patients would ask things like, well, if I'm going to be inactive, am I going to lose my place on the list? So explaining that and talking to them about that. And they want to know, are you taking me off the list? So there was some education that needed to go. No one gave us a hard time about this. They all were very, very understanding, but they just wanted to know what it meant. So communication with them, explaining COVID-19, about hand washing, avoiding crowds, avoiding mass transit. And boy, in New York, that's not easy, but right now it's pretty much not. It's difficult because it's not going. But as you can imagine, most people get to and from work in New York and patients too, with staff, patients, all get together using mass transit to get to the hospital. So that's going to be a challenge when we restart too. The symptoms to report to us, we taught patients about that. And another thing that Nikki said, she said when she was talking to her patients, she found the best way to clearly identify the needs of your patient during this time is to directly communicate and talk with them. And she said patients were great about it. Teaching them about the technology, telehealth. We use Epic, so we go through MyChart to do all of our communication with them. And Nancy told me that the University of Rochester actually did some voiceover with their PowerPoint slides to be able to continue communicating with them and educating patients. Next slide, please. What strategies do you plan to continue after this pandemic is over?
Well, I would say in terms of strategies, we certainly continue to plan for pre and post telehealth visits. And of course, that's as long as legislation allows us to do that with reimbursement for these visits with physicians and other staff members. We have to ultimately maintain financial viability to keep this going. Also, I really think it's important that we review data and outcomes of post-transplant patients as we move more towards virtual visits, just so that we can ensure that in changes with efficiency that we're not having a downward trend in our outcomes. So also evaluating the usage of virtual evaluations. You know, we started with the pre and post, but in terms of pre-transplant, I definitely think there is some value to be had in a number of our satellite clinics. It is a tremendous drain on resources with satellite clinics in terms of staff, costs for rent, loss of productivity when staff are not on campus. And it's not to say that we would look at eliminating outreach clinics, but I think it's an accent to care in satellite clinics.
Thank you. I think the next slide might be yours too. Next slide, please.
Okay, sure.
So how do you believe you're going to function differently after the pandemic?
So I think many programs around the country for years have tried to limit the evaluation, particularly in kidney, to a day to be efficient for patients. But I think that's at a cost. And that cost comes down to the amount in which patients learn and the amount of preparation for these patients in terms of what's to come. So I think as we move away from that, I feel like if we're going to use virtual visits more, maybe we should think of not doing it all in one day, but rather in pieces. In terms of face-to-face visits, again, just reducing those visits. You know, here in the Bronx, we live in a socioeconomically challenged community. And so many patients that aren't benefiting from additional education or access to support groups, for example, may benefit with the expansion into virtual groups. So.
Thank you. Next slide, please. And I guess that's me. So this was one question that several people asked. What are you considering for the recovery stages? Well, we're just beginning to see a flattening of the curve, but it's very slow going as far as the flattening goes. So we want to move slowly with patient and staff safety as a priority. And most patients and staff are required, as I said earlier, to use mass transit. So somebody may be COVID negative on the way to work on Monday, but by Friday they might be COVID positive because of the fact that you can't be 6 feet away. So I'm not sure how quickly we're going to move back to that kind of environment. We're being pretty conservative about this. This has been, I know Laura described a warlike situation, and I have to say, there's been many times that our surgeons who have been working in the intensive care units and our nurses in the ICUs have been saying, it is warlike. It is just like a war zone. One thing I'd like to ask you to do is when you're preparing your staff for this, these patients have a lot of pulmonary issues, which is why so many ventilators are needed. So with these pulmonary issues, we're finding that we have to do what's called proning. And we had only ever done 2 pronings before with our ventilated patients. So we now have a team that goes around to help the nurses with the proning. So you really need to start working on that. And one of the surgeons also told us that when he was on from 7P to 7A one night, we had 20 rapid response calls for ventilation. So think about that too. And is your rapid response team, are they ready to handle that kind of volume? It was pretty busy. So back to my question about recovery, slow progressive movement. First, we want to ensure that COVID admissions are at a minimum compared to the past few weeks. And as Bridget said earlier, we've kind of become at one point a COVID hospital. I think many of us did. So one of our goals is going to be to make sure we have COVID-free units, and we're working on that right now. Test all patients prior to admission to a COVID-free unit. We're going to be redesigning our ambulatory care, prioritizing patients in ambulatory clinic, those with the greatest need for face-to-face, as Laura said. So those who can be managed with telehealth, we're definitely going to do that. When we get back to that too, we also want to increase the time between patient appointments so that we decrease the volume in the waiting rooms. And we may have to track these changes to determine the outcomes too. And we may need to change follow-up policies because there hasn't been anything for us to follow as far as a protocol or a policy. None of us have ever experienced anything quite like this. There was increased use of telehealth. We used it for our heart and lung patients. Now we're using it for all of our transplant recipients. And I think that will be used even more, especially if the restrictions that were listed earlier for payment and licensure across state borders remain. That will help us immensely. Next slide, please. And I just wanted to mention 2 articles that I was reading this week from Harvard Business Review. What will the U.S. healthcare look like after the pandemic? And what will work-life balance look like after the pandemic? I think those will be 2 really good articles for you to get. And you can just go online and do a Google search for Harvard Business Review. Next slide, please. And I just have to do a shout out to our friends in Boston. The New England Patriots. I'm a staunch, longtime Giants fan, but I have to say this. The New England Patriots were just amazing. They took a plane over to China, brought back all these N95 masks, and they brought 300,000 of them with the Massachusetts State Police bringing them over here. And they brought them to New York City for coronavirus relief. I cried. It was just amazing. And then the other shout out is to our friends in Oregon, California, and Washington that sent ventilators to New York City, even as they themselves were fighting the coronavirus at home. People are so amazingly thoughtful. So thank you. We've had a real struggle here in New York, but we couldn't do it without our friends. So thank you very much. Nancy, are you back on?
I am. My sound came back, so thank you for jumping in and taking over. We appreciate everybody participating, and we are going to have, there's a tip sheet, and we'll try to get a summary of the questions put together as well.
Thank you for all your help. You guys have been great at UNOS. We really appreciate it.